Usually a broken bone feels like just a simple problem of structural engineering. You look at the x-ray, you see that jagged white line. A doctor sets the bone in a cast, and it heals.
Right, yeah. Like fixing a broken table leg.
Exactly. But today, we're looking at a massive stack of clinical data that proves our skeletons aren't just static scaffolding at all. Today's deep dive is about what happens when the demolition crew inside your own bones starts working, well, faster than the construction crew.
And how a chemical originally used to unclog 19th century oil pipes became the ultimate biological weapon to stop it.
Right. It is a genuinely wild journey.
It really is. I mean, we are looking at a topic that bridges industrial chemistry, advanced cellular biology, and, a masterclass in how human beings perceive risk.
Yeah, and whether you are a medical student prepping for a pharmacology exam, someone trying to understand a parent's confusing new morning pill routine, or if you're just insanely curious about how the human body works, this deep dive is for you.
Absolutely. We are exploring a class of drugs called bisphosphonates.
And the stakes here are not just some minor inconvenience. If you look at the data in the sources, it highlights that an untreated osteoporotic hip fracture carries a devastating 20 to 25% one-year mortality risk for older adults.
Which is staggering.
It is. Protecting the skeleton is quite literally a matter of life and death. Okay, let's unpack this.
Well, to really understand how these drugs save lives, we kind of have to completely discard the way most of us visualize the human skeleton.
Right. You probably picture bone as an inert frame, like the steel girders holding up a skyscraper. You build it once, and it just sits there.
Yeah, but bone is actually highly active living tissue. It is constantly being torn down and rebuilt in this lifelong process called remodeling.
I really love the analogy from the research here. If you picture your own skeleton, right now, it is essentially a continuous microscopic construction site.
A very busy one.
You've got the demolition crew, which are these specialized cells called osteoclasts, and they attach to the bone surface and secrete powerful acids and enzymes to dissolve the mineral in the collagen.
And then working right behind them, you have the construction crew, the osteoblasts.
Right.
And their job is to lay down fresh, new bone matrix. So in a healthy young adult, those two crews work in perfect synchronization.
The demolition perfectly matches the construction.
Exactly. But in a disease like osteoporosis, that biological balance just completely tips. The osteoclasts, that demolition crew, start tearing down bone much faster than the osteoblasts can ever hope to rebuild it.
So over years and decades, the bone becomes porous, incredibly fragile, and just highly prone to snapping.
Which brings us to the drugs themselves, the bisphosphonates.
And this is a great place to bust the first massive misconception we found in the source material. Because when most people hear osteoporosis drug, they logically assume it's a medication that builds new bone.
Right, which makes sense intuitively, but it doesn't do that at all.
It does absolutely nothing to build bone, does it?
No, it doesn't. These drugs are anti-resorptive, not anabolic. That means they do absolutely nothing to stimulate the construction crew.
They just slow down the demolition crew.
That is their only job, yeah.
But the way they freeze that demolition crew is where this story takes a massive left turn, because medical science didn't even invent these drugs.
No, industrial chemistry did.
Right. The first bisphosphonate compound was synthesized in Germany way back in 1897, decades before a single doctor ever considered putting it inside a human body.
That's because, for the first half of the 20th century, bisphosphonates were strictly industrial anti-scaling agents.
Like for treating hard water.
Exactly. When you have hard water in industrial systems, whether that's a massive laundry facility, agricultural fertilizer vats, or, commercial oil field equipment.
Calcium carbonate precipitates out of the water.
Right, and it forms these hard rock-like clogs in the pipes. So bisphosphonates were added to the water to stop that calcification from happening.
Wait, so we are literally treating our fragile human skeletons with industrial pipe descaler. How on earth does that not just destroy the rest of the body?
I know, it sounds horrifying on paper, but the underlying chemistry is what makes it so elegant. If we fast forward to the 1960s, the sources detail the work of a Swiss physician-scientist named Herbert Fleisch.
Who is now widely considered the father of bisphosphonates.
Right, and Fleisch wasn't looking at oil pipes at all. He was studying a naturally occurring molecule in the human body called pyrophosphate.
Pyrophosphate. That's the molecule that naturally regulates calcification in our bodies, right? Like,
Okay.
It keeps our soft tissues from accidentally turning to bone.
Precisely. Fleisch realized pyrophosphate was a brilliant natural defense against unwanted calcification. But he hit a massive wall in his research.
Because you couldn't just give patients natural pyrophosphate as a medication.
No, you couldn't. If you swallowed it or injected it, the enzymes in your digestive tract and bloodstream would just rip it to shreds in minutes.
Oh, wow. Why is that?
It has a specific chemical structure. It's a phosphorus-oxygen-phosphorus backbone, POP, and human enzymes, called pyrophosphatases, easily slice right through that central oxygen bond, destroying the molecule entirely.
And here's where it gets really interesting. Fleisch and his team are stuck, and they just happen to look at the industrial bisphosphonates sitting in chemical supply catalogs for water treatment.
Yeah, they realize that those industrial chemicals are basically synthetic twins of natural pyrophosphate, but with one tiny, miraculous difference.
In the lab, chemists had replaced that central oxygen atom with a single carbon atom.
Exactly. So it goes from a POP backbone to a PCP backbone.
And that single atomic swap from oxygen to carbon changes everything.
It creates a ragged, non-hydrolyzable bond. It is essentially armor plating the molecule against human enzymes.
That is wild.
Because of that one carbon atom, the drug can actually survive in the harsh environment of the bloodstream long enough to reach the skeleton and do its job.
But if this drug is practically indestructible in the body, how does it know where to go? I mean, it's basically synthetic armor floating in your blood.
Yeah.
How do we ensure it doesn't just build up in the heart or the liver?
Well, this brings us to one of the most remarkable self-targeting mechanisms in modern pharmacology. Bisphosphonates have this extraordinarily high chemical affinity for a mineral called hydroxyapatite.
And hydroxyapatite is the primary mineral crystal that makes up our bone structure.
Yes. Because of that chemical hunger for bone mineral, when the drug enters the bloodstream, it doesn't distribute evenly through your organs.
Right. It makes an absolute beeline for the skeleton.
And not just anywhere on the skeleton either. It selectively targets the active demolition sites.
Because that is where the bone mineral is freshly exposed by the osteoclasts.
Exactly.
It's the ultimate Trojan horse. The drug rushes to the demolition site and binds directly to the bone surface. It literally hides out in the very bone mineral the enemy cell is trying to eat.
Right, so when the osteoclast secretes its acid to dissolve that patch of bone, it unwittingly ingests the drug right along with the mineral.
The enemy smuggles the poison into its own cell through its own feeding process. I love that.
The Trojan horse analogy is perfect, but, what happens once the drug is inside the cell? That depends entirely on which generation of bisphosphonate we are talking about.
Which brings up our second big misconception from the research. The idea that all bisphosphonate prescriptions are basically interchangeable. I think people assume a bone pill is just a bone pill, but they absolutely are not.
Far from it, yeah. The early days of this treatment relied on first-generation drugs like etidronate. These are non-nitrogen-containing bisphosphonates.
Okay, so how do those work?
Once they get smuggled inside the osteoclast, they get metabolized into a fake, highly toxic version of ATP.
And ATP is the basic energy currency of every cell in our body.
Right. So the osteoclast tries to use this fake energy, but it obviously can't. The fake ATP accumulates, completely jams up the cellular machinery, and triggers apoptosis.
Which is programmed cell death.
Exactly. The cell essentially chokes on fake energy and dies.
Okay, that makes sense. But then, as the sources explain, researchers eventually developed the second and third generation drugs. The nitrogen-containing bisphosphonates, like alendronate and zoledronic acid.
Yeah, and these have a completely different, anatomically, astronomically more powerful kill mechanism.
Oh, really? What do they do?
Inside the osteoclast, these newer drugs act as highly targeted enzyme inhibitors. Specifically, they block an enzyme called FPPS.
FPPS. Yeah.
Which sits inside a complex biochemical chain reaction known as the mevalonate pathway.
Okay, I recognize that term.
What's fascinating here is that this is the exact same metabolic highway that statin drugs target to lower your cholesterol.
Wait, time out. Let's make sure I'm getting this. Are you saying that bone pharmacology and cholesterol pharmacology are essentially sharing the exact same biochemical highway?
They are. It's a shared pathway, just utilized differently depending on the cell type. In the osteoclast, the mevalonate pathway is crucial for a process called prenylation.
Prenylation.
Think of it this way. The cell needs to attach tiny lipid tags to specific signaling proteins. Proteins with names like Rho and ROC.
Okay, let me just try to translate that. These lipid tags are basically the ID badges that let the air traffic controllers, these Rho and RAC proteins, do their jobs.
That's a brilliant way to frame it, actually. These air traffic controllers dictate the physical structure of the cell. They tell the osteoclast how to organize its internal skeleton.
And crucially, how to maintain its ruffled border.
Yes.
The ruffled border being that specialized suction cup membrane it uses to attach to the bone and pump out the dissolving acid.
Exactly. So when the nitrogen-containing bisphosphonate blocks the FPPS enzyme, the cell can no longer print those ID badges, those lipid tags.
So without the tags, Row and Rock are locked out.
They can't direct traffic, the osteoclast loses its structural integrity, the ruffled border literally collapses.
Wow.
The cell detaches from the bone, it can no longer resorb mineral, and eventually it just dies.
And because this targeted enzyme inhibition is so surgically specific, these newer drugs are wildly more powerful. According to the sources, a third-generation drug like zoledronic acid is roughly 10,000 times more potent at stopping bone resorption than the original first-generation drugs.
10,000 times! That massive leap in potency revolutionized how we treat osteoporosis. But it also leads directly to some of the most rigid, frustrating, and frankly bizarre dosing rules in all of modern medicine.
Oh, the dosing rules. If you're listening to this and you've ever known someone, maybe a parent or grandparent, taking an oral bisphosphonate like alendronate, you know it's practically a religious ritual.
It really is.
Because the oral bioavailability, meaning the amount of the swallowed pill that actually makes it into the bloodstream, is almost non-existent. It's under 1%.
More than 99% of the pill is just destroyed or passed right through the body. It gets neutralized by stomach acid. It binds instantly to any rogue food or calcium in the gut.
It violently struggles to cross the gut wall.
Exactly. So to get that precious fraction of a percent into the blood, the daily routine is extreme.
You have to wake up and take it first thing in the morning on a completely empty stomach.
With a full glass of plain water only.
Right. If you take it with coffee or orange juice or even mineral water, you completely ruin the absorption. And then you must wait at least 30 to 60 minutes before you eat or drink anything else.
But here's the craziest part to me. You have to remain completely, strictly upright for that entire waiting period, sitting up straight or standing.
You cannot go back to sleep or lie down on the couch.
And that upright rule is absolutely non-negotiable because the drug is incredibly caustic to esophageal tissue.
Meaning, if the pill gets stuck in your throat, or if you lie down and experience even mild acid reflux, the drug can wash back up and linger in the esophagus.
And if that happens, it can cause severe erosive esophagitis or deep ulcerations.
It will literally burn a hole in the esophageal lining.
Yes.
This is where I have to push back a little on behalf of the patient. If the oral pill is so easily destroyed by just a sip of coffee or a bite of food, and yet it's so caustic that it could burn a hole in your throat if you lie down, how is this a viable long-term treatment? How do we make sure patients actually get the benefit without accidentally ruining the dose or injuring themselves?
Well, that exact clinical frustration is what drove the development of the 5E formulations. The Horizon trial in the mid-2000s was a massive breakthrough here.
It tested zoledronic acid, right?
Yes, that incredibly potent third-generation drug, but given as a single 15-minute intravenous infusion just once a year.
Once a year.
Bypassing the digestive tract entirely, no empty stomach rules, zero heartburn risks, no standing up for an hour.
And the clinical results were absolutely stunning. That single annual infusion reduced vertebral fractures by roughly 70% and hip fractures by around 40% compared to a placebo.
It is genuinely wild to think about. A 15-minute drip protects your entire skeleton for 365 days.
And that is entirely because of what we talked about earlier, that extreme Trojan horse chemical affinity for the bone mineral. The drug locks into the bone and physically stays there.
Right, it creates a durable mineral reservoir deep inside your skeleton. With most medications, like a blood pressure pill, you need a constant, steady level of the drug circulating in your blood every single day.
But here, the drug clears from the blood in hours.
It is literally embedded in the skeleton, lying in wait for an osteoclast to come along and try to eat it.
Which leads perfectly into a concept that is practically unheard of with other chronic diseases, the drug holiday.
It is a remarkable, unique feature of this drug class. The skeletal half-life of a bisphosphonate, meaning how long it remains biologically active inside the bone, can be a decade or more.
A decade. Because the skeleton has this incredibly long memory, a patient's bone continues to receive the fracture prevention benefit long after they actually stop taking the medication.
Yeah, so for patients who are at low to moderate risk, doctors often recommend they just completely stop taking the drug after 3 to 5 years.
You stop taking the pills, and the chemical armor just keeps working. which busts our third big misconception, that longer treatment is always better.
That instinct makes sense for almost every other disease, but not here. The FLEX trial highlighted this perfectly. They took patients who had been on oral alendronate for 5 years and randomized them to either stop the drug entirely or continue for another 5 years.
And for non-vertebral fractures, there was no significant overall difference between the two groups.
Right. Pushing past 5 years didn't offer a massive additional benefit for the average patient, but it did drastically increase the risk of some very rare, very strange complications.
And this brings us to the dark side of this medication, because freezing bone turnover for too long has consequences, and led to arguably the most dramatic part of this entire story, the communication failure and the public panic.
Because a drug that you can stop taking but keeps working sounds like magic until you realize that suppressing the skeleton's natural demolition crew for a decade causes a new set of problems.
We have to remember that bone remodeling isn't just about losing density. Remodeling is the only way the skeleton repairs microdamage.
Every single day when you walk, run, or jump, your bones sustain microscopic structural cracks.
Normally, osteoclasts come in, clear out that tiny damaged area, and osteoblasts fill it with fresh, flexible bone.
But if you shut down the osteoclasts for 5 or 10 years straight,
The microdamage accumulates.
exactly, the bone might look thick and dense on an X-ray, but it actually becomes brittle, like old chalk.
And this led to 2 highly publicized adverse events. The first is atypical femoral fractures, or AFF.
Yeah.
Starting around 2005, orthopedic surgeons began seeing unusual, spontaneous snaps in the thigh bone, the femur.
Patients would experience a dull, aching thigh pain for weeks, and then their femur would just snap cleanly across the shaft, often from something as minor as stepping off a curb.
It's terrifying. And the second complication, which arguably scared the public even more, was ONJ, osteonecrosis of the jaw.
This is exposed, non-healing, dead jawbone, usually triggered by a routine dental extraction.
But if you look at the data in the sources, it reveals a massive disparity in who was actually getting ONJ.
It does. ONJ was primarily happening in cancer patients, specifically people with bone metastases or multiple myeloma.
Because in oncology, bisphosphonates are given intravenously at much higher, much more frequent doses to prevent skeletal tumors from destroying the bone.
Right. In that high-dose cancer population, ONJ risk is estimated between 1 to 10%. But for a standard osteoporosis patient taking a weekly oral pill, the risk is incredibly low, often cited as 1 in 10,000 or even 1 in 100,000.
It's the exact same chemical, but a wildly different risk profile purely based on the dose. Yet when this hit the media, that crucial nuance was completely lost.
Completely lost. There were thousands of lawsuits against Merck over Fosamax. The evening news ran horrifying, sensational stories about people's jaws rotting or their femurs snapping in half on the sidewalk.
And the result was a catastrophic drop in osteoporosis prescriptions across the board. This created a massive treatment gap. Millions of people who desperately needed the drug stopped taking it or refused to start.
And the research clearly links this drop in prescriptions to a subsequent documented rise in deadly hip fractures.
It's awful.
If we connect this to the bigger picture, it is a profound, somewhat tragic lesson in how human psychology distorts medical decision-making. We are biologically wired to fear vivid, gruesome narratives.
The snapping femur or a dying jawbone is a terrifying, highly visible image.
But the primary benefit of the drug, not breaking your hip, is entirely invisible. It's a non-event. It is exceptionally hard for the human brain to value a disaster that didn't happen.
But if my jawbone might actually die, or my femur might randomly snap while I'm walking to the mailbox, aren't patients entirely justified in being terrified? How do you weigh a rare risk against an everyday fear?
It's a completely valid emotional response from the patient. But this is where we have to rely on the base rates, which busts our final misconception, that these rare risks mean the drugs should be avoided altogether.
You have to compare the risk directly.
Right. The risk of an atypical fracture might be 1 in several thousand after years of continuous use. But the risk of an elderly woman dying within a year of an osteoporotic hip fracture is 20 to 25%.
Wow.
The sheer mathematical reality is that for eligible patients, the benefit of preventing a hip fracture astronomically outweighs the risk of the rare side effects.
It is a tragic irony. In trying to avoid a 1 in 10,000 complication, thousands of people walked blindly into a 1 in 5 mortality risk.
And that fundamentally is why the drug holiday was implemented by the medical community. By strategically stopping the drug after 3 to 5 years, you allow bone turnover to wake up just enough to repair that accumulated microdamage.
This drastically lowers the risk of atypical fractures and ONJ while still maintaining the fracture protection from the residual drug deeply embedded in the bone. It's a brilliant pharmacological compromise.
It really is.
It's incredible to trace this entire journey. We started with an industrial chemical used to descale oil pipes in 19th century Germany. Then, a genius carbon atom swap turns it into indestructible armor.
It becomes a precision Trojan horse that hides inside our bone mineral, poisoning the exact cells trying to destroy our skeleton.
By blocking the same biochemical pathway as cholesterol drugs, no less. And yes, the dosing rules are miserable. You have to stand perfectly upright for an hour on an empty stomach just to get a fraction of a percent of the drug into your blood.
But understanding why those rules exist, understanding the true scale of the risk versus the massive reward of preventing a deadly hip fracture, it completely transforms how you look at that little prescription bottle.
It's not just a pill. It's a carefully calibrated pause button for your skeleton. So what does this all mean?
Well, it points us toward an incredible future. Everything we've discussed today, the bisphosphonates, is essentially about pausing destruction. They just freeze the demolition crew.
Right.
But as the sources point out, the newest frontier in bone pharmacology involves anabolic drugs. Medications like teriparatide or romosozumab, these don't just stop the osteoclasts, they actively stimulate the osteoblasts.
They order the construction crew to build brand new, fresh bone.
Exactly.
Yeah.
If we now have the perfect chemical tools to completely halt skeletal destruction, and we are unlocking the biological secrets to aggressively stimulate new construction, we are approaching an era where an aging, fragile skeleton isn't just preserved.
It can actually be reverse-aged.
Yes. That jagged white line on an X-ray might become a thing of the past because we are finally learning how to treat the human body not just as static scaffolding, but as a structure we can completely rebuild.